We'll go ahead and get started with our breakout. I invite all of our panelists to come on to camera and get ready. Hello to everyone, and thank you for joining today. My name is Gage Dalton. I am a public health analyst from the Office on Women's Health, and I'm incredibly excited to continue the NWBPAW Summit with this panel focused on partnering with your community to advance hypertension control. Our panelists today are some of the awardees of Phase 2 of the HHS Hypertension Innovator Award Competition, a challenge from the Office on Women's Health to identify innovative methods of blood pressure monitoring and follow-up in women during pregnancy and/or postpartum. And making up our panel today are Courtney Williams from Imagine Solutions Technology, Dr. Ann Chaley from Brigham and Women's Health Hospital, Dr. Daniel Lasser from New York City Health Plus Hospitals, and Dr. Christina Yarrington from Boston Medical Center. And each of our panelists has done great work to advance the field of hypertension through their programs. And it's a sincere pleasure to have each of you join us today. To kick off this panel, could each of you share how you have partnered with your community in your work? And Dr. Yarrington, could you start us off specifically in this conversation with some of your experiences engaging with patient feedback and diversifying providers?
Sure, I'm happy to. Thank you, everyone, for coming to our panel today. I'm a high-risk pregnancy doctor, a maternal fetal medicine doctor working in a safety net hospital in Boston. And my work within hypertension started in our postpartum population, equipping any postpartum person at risk for hypertension with a particular kind of blood pressure cuff that could transmit the data back to us centrally. So the patient had to do very little. If she checked her blood pressure, I would know the number. I would reach out to facilitate care. In this phase 2, we sat with a number of our Black birthing patients in particular who had experienced hypertension or preeclampsia during their birth with us, and conducted a series of semi-structured interviews to ask about the experience. What got in the way of good care, what represented good care to them, and what would they hope for in a future pregnancy. And based on that, we expanded our program to do some of the same technology, the same approach during pregnancy. So not just postpartum. And we're learning a lot in real time about that, because for some of our patients, this incites a lot of fear. And for some others, it's reassuring that they have this tool. And so that we're yet to really explore in terms of our full engagement with our most important stakeholders, our patients. But the other thing I offered to this discussion is the inclusion of our full community of providers. One of the biggest walls for many programs in implementing remote blood pressure intervention for their postpartum population, despite knowing that it's a significant source of harm for the women and the postpartum people, is that there's not a way to staff it. It's really hard to justify spending MD time on that. That's really expensive. And so what we've done that is new is I reached out to our community of pharmacists. We have a central nurse who manages the data, talks to our patients, communicates, and ensures that there's a good bridge. But for medications, when we need to initiate or titrate, we actually partner with our pharmacist team. They're very skilled in the primary care world, family medicine world, certainly anticoagulation world. They know how to start and change medications. And so we built out a contract based on algorithmic care, and that has transformed our ability to reach people, particularly in a time-efficient way. And honestly, I think it's something that can be scaled to a pretty significant degree, and I'm happy to talk more. But I'll turn over now to Courtney Williams.
Thank you so much. It's nice to see everybody, and thanks. We'd like to reiterate, thanks for being here and caring so much about this subject with your time. Courtney Williams, I'm co-founder and CEO of Imagine Solutions Technology. We are a health tech company, and we're tackling the U.S. maternal health crisis with technologies that make pregnancy care safer and lower costs and improve outcomes. We are your companion for a safe pregnancy, is what we say. We've really developed a suite of maternal health tech products that really help doctors and patients during the prenatal care journey. And so that includes, we have an FDA cleared handheld ultrasound that's used by providers, and a patient app called The Journey Pregnancy, which I'll talk about in a moment, and then also remote patient monitoring software for providers. So we're really bridging the gap between patients and providers with the technology that we developed. Unlike my colleagues here on this panel, I am not a provider. My background is that I'm an MBA with customer analytics and international business background. But I had a high-risk pregnancy at the height of the COVID period, and I got preeclampsia in the postpartum period. I was frustrated because I had actually no way to communicate my symptoms, my blood pressure to my doctor. So I had to keep going into the office, putting my family at risk, putting my providers at risk, frankly, just to get blood pressure readings multiple times a week. So with my team, I developed an app called The Journey Pregnancy so that nobody else would have to go through the same thing that I did. The Journey Pregnancy is a maternal health tool. It's a free download on the iOS and Google Play Store. And anybody can use this from their positive pregnancy test all the way through 3 months of their postpartum recovery. It's basically creating a digital permanent log of pregnancy health for each patient. And you can log your symptoms, your vitals, your mood, your blood pressure, your blood glucose, heart rate, temperature, et cetera. And then patients can share this information directly with their provider, with their healthcare team, even with a pregnancy wellness coach. Over the past 9 months since we started the phase 2 Hypertension Innovator Award period in January, we've actually grown by 10x to over 2,500 users on our app, The Journey Pregnancy. We have 600 new followers on Instagram. We've 4,800 new likes on Instagram, 45,000 views of our videos on TikTok. And during this period, we really listened to patients. A lot of folks in their first-time pregnancies or people that are high risk have indicated that they want more hand-holding. They want more time with their providers. Providers are really, really overwhelmed and busy and have heavy caseloads. And so we added pregnancy wellness coaching so that a patient can directly connect with a nurse practitioner and ask questions that they may not have time to ask their provider. Patients who've used it so far have really said it's a lifesaver, and it's really reduced their stress in pregnancy and helped them manage their blood pressure particularly better. Well, I'll just kind of wrap up by saying we haven't done any marketing for our solution yet. But the people that need us are really finding us, and this technology is really striking a chord, mostly because we're connecting primarily with patients, and patients historically have been wanting ways to advocate for themselves more, have been wanting ways to understand their pregnancy health better, instead of just going to TikTok to get health information, which is what most people are doing, scarily enough. And so we've partnered with a number of different clinics across the Southwest and the Midwest, and we're really expanding our footprint with both our app and our remote patient monitoring software. So I'll turn it over to Dr. Lasser to go next.
Hello. So my name is Dr. Daniel Lasser, and I'm here at New York City Health and Hospital, South Brooklyn Hospital, a large municipal hospital network functioning in New York City that I would say is also very community-based because we have a large catchment area without other local hospitals nearby. So our strategy, which actually started in 2016, involved several different strategies, several prongs. First of all, aimed at patients, but also aimed at changing the culture within providers who are giving obstetrical care to patients, including high-risk patients, and providers who are in internal medicine primary care, to whom we ultimately want to bridge long-term care for our patients who suffer with HDP, hypertensive disorder of pregnancy. So using this approach, we devised a method in which we're trying to hit a population that often has obstacles to receiving care, time obstacles, financial obstacles, social obstacles, and cultural obstacles. So we've done a number of things to try to remove these obstacles. Number one being education, trying to explain about hypertensive disorder of pregnancy as it relates to future cardiovascular health risk, removing some of the mystery surrounding it, because in patient culture, in general culture, in the media, this is an area that has received very little attention, completely in disproportion to how many patients it affects, how many lives, and to what degree it affects. Of course, there's also the health equity aspect, which we must bring up. Our patient population is a very multicultural group, but includes some very high-risk subgroups, those with African American descent, and various other groups that we've taken it as a charge to try to address and improve their health. To facilitate subsequent health after education, we've devised dyad visits, which take place within 3 days postpartum, where a mom and a baby can receive care simultaneously, once again, to remove obstacles to care, to facilitate. And of course, patients love that, but it provides us with the opportunity to assess blood pressure, to assess compliance with medications. More than 60% of our HDP patients actually are discharged on medications, very high proportion, to adjust medications, and then to ultimately and finally bridge care to primary care, one of the most difficult steps, to change the culture within primary care for providers who are not obstetricians or providers who care for pregnant women. There was a certain degree of mystery surrounding this, and it certainly wasn't in the culture to see young postpartum women for heart disease risk reduction. To address that, we engaged in lectures to incoming residents in internal medicine through questionnaires and through feedback. We were able to remove some obstacles in terms of the primary care providers, and ultimately we were able to get carve-out slots for our patients, assigned specifically to our patients so they wouldn't fall low on the priority list somehow. Of course, televisits have been extremely helpful, distributing home blood pressure monitoring equipment with televisits. And we've tried to basically, through repetitive PDSA processes, we have changed the culture. We are getting improvements in compliance, 100% educational compliance with our educational postpartum encounters, and we're getting north of 50% of our patients to return for their primary care visits in a timely way. So I'm happy to report this. I'm very happy to be in the company of so many distinguished panelists, and I want to give a shout out to the staff at Health and Human Services for providing so much support. And I guess I'll pass on to the next panelist.
Oh, Dr. Chaley, you are muted.
That's a problem, right? Hi, so I'm Ann Chaley, and I'm a medicine and pediatrics trained internist at Brigham and Women's Hospital. And back in 2011, we opened a postpartum transition hypertension clinic. And our story is very patient focused. We opened our doors and we opened our ears, and we learned and heard about lots of the same issues that have been really well outlined by so many of the previous, even by the previous panelists. So like Susan Hendricks and Elaine Johannes, the access to blood pressure monitors, knowledge of how to check your blood pressure properly, what to do with those numbers, and empowerment to connect with healthcare providers in the days, the weeks, and the years, months and years after delivery. So full disclosure, like I'm in the end game, okay? I'm in the long-term game. I really want patients to engage for the long term. So I'm there with Dr. Lasser trying to reach out against the aisle to sort of work with my OB providers to do that. So patients' voices have really driven all of our quality improvement and clinical innovation work. which includes, this started a long time ago, blood pressure monitors at hospital discharge, prompts some sort of clinical follow-up. And I love this, the dyad patient follow-up with the mom and baby as a med-peds provider. I'm like loving that. But it's also sort of not just the blood pressure monitors and empowering them to follow up, but really empowering patients for self-care recovery and to learn to put themselves first. Susan Hendricks pointed this out too. Often a lot of our birthing patients really put themselves last at a time when they really need to be cared for and taken care of. And then also attention to wraparound care, which includes resources for social drivers of health. So I'll get into that more later as we get into a lot of the questions. And I talked about it last year, but some of the qualitative research that we did at Ariadne Labs, listening to patients and also obstetric and primary care providers, really we learned and heard about many barriers that would impede patient behavior and the capability or opportunity or motivation to actually engage in their health. And it really amplified the need for patient-focused tools. So a lot of the work that I'm doing right now is I'm doing some co-creation journey on educational tools. They're at reading level grade 6, and without feeling like they're at reading level grade 6, they're gender neutral, they're multimodal and bilingual in Spanish right now from the inception, and using language that really calls patients in rather than calling them out, not assuming that they're not trying to do the right thing or actually already making efforts on their own behalf. Most people are trying to do the best things they can for their health. And so this co-creation journey is also involved, oh my goodness. I'm like the IT disaster today. Anyway, it's also involved interdisciplinary professional society and patient advocacies and foundations. So a shout out to Lenny Tazikas, who's here today from the Preeclampsia Foundation. And we're trying to bridge that divide to engage both obstetric and primary providers to engage and communicate with patients. And Dr. Lasser, I'm also one of the people that speaks at, when the OB interns come, I am one of those people that talks, that welcomes them here. And the first thing I do is I teach them how to, what blood pressure is, how to check it, how to do it right. There's a video that I co-created with the March of Dimes and the Preeclampsia Foundation that I share with them. And I love people to reach out to me, beyondbirth@nwb.org, beyondbirth@nwb.org. Anybody wants to get involved or wants to test or take a look and give us some feedback, let me know. And I'm looking forward to the rest of the panel. Hopefully my light won't go out again.
Well, thank you to all of you. It's always incredibly encouraging to hear about the work you're doing and having this platform to discuss it. Now, with an understanding of how each of you has partnered with your community, what are some strategies that have proven effective in engaging community members, especially those who may have been more resistant? And Dr. Lasser, could you head this question off and expand on some of your history with engaging high-risk populations and working collaboratively with others in your field?
Sure. Thank you very much, Gage, for the introduction. Yes, this is a particularly important area and definitely a challenging area. So we've worked on, and I have to say, with the help of, since we're in a network of municipal hospitals, we've had assistance with this. One of the key components of our care to women with HDP is a program that's called the Maternal Medical Home, which in essence is there to remove the obstacles to care, to remove all of the things that prevent our patients, be that time factors, childcare issues, financial assistance, comprehensive social service intake that aims to remove these things, and also to facilitate patients on a practical level getting their blood pressure monitoring equipment if they haven't been able to get it already, or replacements for ones that have been lost or don't work. It's something that, of course, has received a lot of warm approval from our patients and gives them an extra tie-in to our service, not that we're just a hospital, or just that we're providing acute care or just annual visits, but that we are willing to, in essence, smooth the road for them to obtain their care, and on a level that that they can relate to. Of course, linguistic and culturally sensitive care is crucially important in our population. We have translated all our educational material into 8 of our most common languages, and we haven't even begun to scratch the surface of our less commonly represented languages. Of course, with language translation services that are available, we can do that. But learning the culturally sensitive approach for all our providers has been an essential tool, and definitely very engaging to our patients. So these are some of the techniques that we've had and that are constantly being refined, but we've definitely seen good success in implementing these strategies.
Paige, if I could comment and capitalize on that. Dr. Lasser, I love hearing about your work. I'm inspired every time I hear you talk about the additional steps and barriers that you're dropping for your patients. I think you and I have very similar patient populations, although in different states. And it makes me reflect that our solution to it has been to select a technology that bridges further out. There are many programs around the country that will distribute a blood pressure cuff and then ask the patient to reach back out to them. And from the onset, we chose a technology where the patient had to do very little and we all came to them. But that was where we hit the barriers with our other communities of providers. That it was much more of a lift that I was asking of the community providers at Boston Medical Center to complete that bridge. And just to underscore, that's where thinking creatively about who can do this. I think a lot about, we have a good solution. How do you implement it? How do you actually make it happen? And that is where I pulled in our pharmacists, which I know is very banal and not very sexy, but it's made it possible. And the integration of that team in our practice has gotten more prescriptions into people's hands faster, because our pharmacy system not only will leverage the pharmacist to write it, but they'll use the courier system to get the prescription itself to the woman's door by the end of the day. And blood pressure changes so quickly within HDB, hypertensive disorders of pregnancy. Day to day, there can be a shift. And I feel our panel working in both sides of this, the short-term game to reduce severe maternal morbidity related to hypertension, and then absolutely Dr. Celli's work to make sure that the rest of the person's life is well wrapped around in primary care is what our patients deserve, is what every single patient deserves. And certainly all these steps, the technology selection, the distributed workforce, the consideration and integration of social determinants of care are the linchpins of deconstructing this significant health inequity that our patients of color continue to experience.
If I could jump in there as well, this is a hot topic. Dr. Lasser had mentioned about translation, how important it is to kind of meet people where they are in terms of translation. We experienced the same thing actually over the past year, and we decided to translate our app into an additional, aside from English and Spanish, an additional 8 languages as well, just because there was demand for folks to be able to use it. But from a language perspective, there was a barrier there. And that was something that we determined, like, that's something easy that we can do to make life easier for patients. And so actually part of our HHS Hypertension Innovator Award went to translating. I also think that, like, it's important for patients to see that they are not alone in this. Pregnancy, especially postpartum, can be a really lonely time. And people feel sort of, they've got care while they've got a baby in them. But then as soon as the baby comes out, the mom, the parent, they're just kind of left behind, is a lot of what people feel. And so in particular, we decided to engage more closely with the African-American community and show them that we're walking with them as opposed to telling them what to do on their maternal health journey. And I think that we were fortunate enough to have media outlets cover our work that we're doing. Like, and these are these are places where, you know, pregnant African-American moms are reading already, like Fast Company, Afrotech, Mama Glow. And so members of this community trust those sources, and they saw that we were being talked about it, and that helped open conversations, help boost credibility in the solutions that we're developing. We're not just talking about helping the Black community, but people sort of see me as a biracial woman that's a tech developer working on the problem of maternal health as somebody who not only experiences the sort of microcosm of Black maternal health disparities in my own family, but that our company and our team are trying to do something about it, and that we're walking with members of the Black community, not just telling them what to do. So that has been really, really helpful for us over the past year.
So I'm just going to add in here, you guys have done an amazing job of sort of like covering a bit of the quite an amazing part of the landscape. And in addition to the pharmacists, which Dr. Garrington so articulately pointed out, we do use those in internal medicine, and there are lots of partnering with internal medicine that can be incredibly powerful. And depending on what state you're in and exactly how the ACOs are built and how your public insurance is built and what resources you have, a lot of incredible supports for the social drivers of health really live within primary care. So partnering with those communities can make an enormous, like you can be incredibly fruitful. So how do you partner with those groups? I mean, a lot of it involves co-creation, right? Is that when you're thinking of developing something in that space, rather than throwing something to them, bring them along with you and listen to their voice about what they need. We have a primary care crisis in this country, which I don't think I need to develop any further. Even in a high resource place like Boston, there's an enormous amount of shortages. And so I feel like really thinking about like all the community that interacts with patients. So there was a discussion about community health workers in our first talk here today. You know, doulas, patient navigators, there's community nurse aides. You know, they have different terms depending on what state you're in and what county you're in and who's available. But I think that there's sort of, there's not a one-size-fits-all approach, but really listening to all their voices. And I do actually want to say that as we think about developing our technologies and developing our clinical models, really trying to listen to underrepresented voices that aren't usually represented. Courtney Williams did an amazing job of talking about how she's partnering with the African-American community, but I've become quite interested in Indigenous populations and rural populations. And some of the language that we were using in our handouts, we heard from groups that did a number of work in the space didn't resonate with them because they don't know the term, primary care provider isn't available in all settings for them. That's not how they think about a primary care provider, for example, or it may not be sensitive because, we do this, with the DASH diet and everything, we talk about eat your fruits and vegetables. Well, depending on where you are, you may or may not be able to have access to that. So if you're in an Alaskan Native village, and really the message to them, and there's growing data about this, is to really for them to eat their traditional foods and what they usually do. There seems to be a quite protective effect from that. So I think we just have to be sensitive that there isn't a one-size-fits-all approach. There are many people that are part of the community, and that there's a lot of care and interest out there. And I do agree that reaching across the aisle to primary care doctors to make sure they understand and know that what they think of as low-risk women is not really needing close follow-up. It's actually really important because the OB 140/90 number is not the number we use in internal medicine. We don't like 140/90 at all. So I think that those are the kinds of things we need to remind ourselves about. So Gage, I think we've gotten ourselves really far ahead on questions. So
No, that was such a great transition, and I'd like to open up a question for all the other panelists. Dr. Chaley just discussed how she's partnering with some of her other providers to advance hypertension care through community partnerships. What are some other opportunities that exist in advancing hypertension care through community partnerships? And what would the rest of you like to see in future efforts?
Wait, am I allowed to start off with that?
Oh, absolutely.
Okay.
Keep on going.
So there's been a lot of interest in the obstetric community, specifically the obstetric community, in developing the fourth trimester care plan, which many of those core elements are ones that are really the foundation of a lot of family practice and nurse midwifery. So listening to diverse stakeholders is actually super important. And it's very, very obstetric focused. And if you look at the point plans on the 4th trimester, I mean, it's fantastic, the list. But I have to say, as a general internist, I look at every bullet point and I start getting palpitations, because every single one of those can be a 45-minute primary care visit. I mean, they're incredibly complicated. And it's very hard to unpack that in limited physician time. So technologies like what Courtney Williams is working on, I think are super important to be able to extend that educational space. And I'll talk about that a little bit more. But then the other point is that, we're spending all this time figuring out how to throw the football, but we're not really thinking very much about the wide receivers out there and who's going to catch that football and run with it towards the goal line. And I think that that's really where developing a better dialogue and learning what that dialogue is something that, is something that I'm deeply interested in learning on, because like I said, I'm interested in the end game. I mean, when I talk to patients about primary care, I really spend a lot of time as like some marketing person trying to like market them like this is something that you want, or just engaging with healthcare or engaging with your blood pressure so that you're interested in the long term. And so by pulling in the other groups, cardiologists, endocrinologists, nephrologists, I don't care who you are or what your list is, community nurse aide, community health worker, doula. I think if we can bring them in, then they all get to be sort of part of our team. And we have lots of people out there ready to catch that ball in the end zone. So anyway, that's my pitch.
I've always thought a lot about digital health equity as it applies to the various solutions that we're trying to work with here. The blood pressure devices that we use are cell enabled, and so they don't use the person's data plan, but there does have to be an active cell network to be able to transmit the signal. And while that kind of technology can be distributed across New England, where many of us work on this panel, I recently took a new job in New Mexico, and the distribution of digital access is really not the same out here. And so thinking about how the broad stroke solution of integrating technology to scale access to healthcare is not the same in different parts of the country. And the healthcare disparities persist out here for sure. And with respect to that too, my patient population here, as in Boston, is predominantly insured by Medicaid. And the variation in Medicaid around this country is also going to be a barrier for people to get continuity care after a high-risk pregnancy. Many states have adopted the expansion of coverage to the first full year postpartum, which is a good start. But then what? We need to think on an advocacy level as well. I mean, digital access advocacy, but also political advocacy to ensure population health is really happening here. I'm sure Ms. Williams has thoughts about digital access as well.
I do. I have thoughts. And I echo you with your experience in Mexico. I'm actually based in Arizona. And so similar distribution. I mean, Arizona is actually in the top 10 for worst maternal health outcomes in the nation. Part of it being because we've got a really big disparity between rural and urban folks. And rural, a lot of folks that need to rely on technology can't, or, they're having to travel over 2 hours just to get to their prenatal care appointments. We see that all the time. And so there's a big appetite for patients. People that are rural, they know that they're at an increased risk. They know that they don't have access to the same things that their counterparts that are in more metropolitan settings do. And so there's like an increased need they feel that we, at least based on our research and the folks that we talk to, that people want to be able to advocate for themselves that much more. And so giving them digital tools to be able to do that is really important, but it's only as good as the networks that our infrastructure allows. And so on reservations, in really, really rural spaces, that can be really difficult. And then the digital divide can actually compound these health disparities. And so it's really incumbent upon our leaders to help close those digital gaps so people have access to like broadband and better cellular service so that they can then level up some of those health outcomes. So I totally agree with you on that.
Yeah, I'd like to jump in here too, and I want to take a different direction and emphasizing, I believe, how important the role of media is in getting the message across to our patients, the ones who need it the most, even to people in the general public. We're living in an age where I think we need to somewhat face up to the fact that it isn't really true until the media says so. So we've tried to address that issue. Number one, by we're creating an educational video for our patients in multiple languages, so that we're not just it's not just an encounter. Even though with a respected provider, you're not just taking our word on it. We've also done a number of public service TV interviews regarding hypertensive disorder of pregnancy, what it is, what it involves, how you can protect yourself from future heart disease, those sort of things that are being broadcast on local networks. I really believe that the media has been very remiss, just like a reflection of society at large about hypertensive disorder of pregnancy. It's still kind of hidden in the shadows. I think, that could be a very fruitful way to reach especially our underprivileged patients and get them more involved.
That's really great. And thinking on this and what you would like to see in the future, what are each of you learning from your community partners that you would like the audience to know? And Courtney, you kind of already started sharing on this already, but could you share from your experiences working to overcome barriers for women that are tracking their health using your app?
Yeah, definitely. When we talk about community, it's kind of interesting because not being a provider, we're actually really straddling multiple communities. So it's sort of like, wow, which lens do I answer that question with? So first of all, we're a startup tech company. And so startup tech has its own culture. We're in the women's health tech community. Femtech is this term that we've been hearing thrown around. I've thoughts about that term, but we'll just roll with it. And then also we deal specifically with the community of patients, and we have a growing community of providers that we're working with. So let me break each of those down briefly. So being part of the Femtech community, we've learned that sort of other tech developers and other folks that are working on technology solutions to combat various challenges in women's health, not just maternal health, but women's health, the whole spectrum. These companies are really operating in silos. There's very minimal coordination. There are these amazing things that are being developed sort of in black boxes, and many of them are coming up with solutions and then just pushing them onto either patients or providers. Not a lot of feedback going either way. And that's actually not the way that we operate. And we see that happening. We're like, that's 100% the opposite of what we want to do. So we're based on being a part of that community. We've decided that we want to be a partner, and our culture, at least to ourselves, is really to be a partner that works collaboratively. So for that reason specifically, we participated in a program through National Science Foundation, and we interviewed, hundreds of patients and providers in a really short period of time to understand what their pain points are in the maternal health journey, and to understand those better. And then that helps us develop better collaborations. Being part of the patient community, we're involving patients constantly to get their ongoing feedback about our app, challenges they experience, bugs. People know that they can just email me and let me know if they have a challenge or they want to see something different. And they do, get screenshots all the time. We've also learned specifically, and I kind of touched on this before, that, patients really want to be involved in as much as they can about their maternal health journey. They want opportunities to advocate for themselves. They want to feel prepared for their visits with their provider and their conversations with their doctors. So listening to that, we added actually a section in our app for women to document conversations questions specifically they want to ask their doctors at their next appointment. Patients want more access to verified information about pregnancy health. So we added a resource with, hundreds of research-backed articles that really span all different types of subjects about pregnancy health into our app as an educational resource. And we did that because we know, after talking to our patients, that many of them are getting their information from TikTok about their pregnancy health, or Facebook in a worst case. And so providing research-backed articles in a verifiable setting has been really helpful. And then I'll just also say that women, especially women of color who compose of over 60% of our current app users, they as I said before, they really want ways to advocate for themselves. So we listen to that, and we're expanding the different types and the amount of information that people can document into our app. And we're expanding ways for them to connect their various wearable devices into our app, their Fitbits, their multitude of blood pressure cuffs and other devices that they're already using, so that that information can interface. And, when they get a blood pressure alert, they can immediately act on that and contact their provider. Lastly, I'll just say that we've learned from doctors how important it is for them to save time. Doctors are so overworked. The maternal healthcare provider shortage is a real thing. It's getting worse. Doctors are getting bigger and bigger caseloads of patients. And frankly, the caseloads are like folks that are sicker and older giving birth. And, the increase in preeclampsia and gestational diabetes rising at like 19 and 16% respectively are really burdens on everybody. And so giving folks a tool to be able to communicate directly to their provider, so the provider doesn't even have to worry about that. The information's right there for them. We found that has been really helpful, and that's leading us to integrate with EHRs, et cetera, to make it easier for providers to be able to act. So I'll turn it over to my other panelists to weigh in.
Can I just jump in really quickly with one quick thing on something you just said, Courtney, which is that the maternal health care deserts is a real thing, and it's growing since the Dobbs decision. And there's been a lot of articles in the media about this. Any obstetric provider, even family practice doctors that are willing to do obstetric procedures. And so that's really a big concern. And it's actually one of the reasons why it is so important that we engage family practice doctors, and we engage the community nurse aide and the community health workers in these sort of basic, like really fantastic ways of saving women's lives. I mean, it's one of the biggest causes of cardiovascular death worldwide is hypertension, is uncontrolled hypertension, and so this is low-hanging fruit, quite honestly, in terms of something you can measure as an internist. So it's a little bit of an infomercial to reach out to those people, that diverse group on the ground.
My last observation that I want to share with you all is I learn and relearn every day that blood pressure is a strangely intimate vital sign. The lessons we've learned from our patients are that the experience of it is quite different prenatally and postpartum. Postpartum, we're using this tool to identify people at risk primarily. And honestly, as a doctor, I thought that's what we would learn of the prenatal population, but it's almost the opposite. What we see is the blood pressures that are obtained when they're in front of me, their high-risk doctors jump up. When they're in front of me, the white suburban girl jump up. And that's not the way to make the best decision about that patient. And the ability to check a blood pressure at home in her or their own environment under their own control is what really can dictate best care. During pregnancy, we do interventions to people when their blood pressure goes up. We may recommend the baby come out that day if their blood pressure goes up. And so it's really critical that the intimacy of that vital sign is respected.
I would just like to say that I agree with what Dr. Yarrington just said. I want to commend all my colleagues here, Dr. Chaley, Courtney Williams. Everybody's input on this has been so enlightening, and I think through our different approaches, I think that's the beauty of the system that's been built through this program. Is there's creativity that can be directed in different directions to facilitate the result, the end product. I totally agree about what you're saying about single blood pressure determinations not being truly representative of the biology of the patient, possibly analogous to our move from finger sticks to continuous glucose monitoring. A lot of parallels there. There's plenty that can be done, and I think, of course, being able to feed back to the patient on their status is super important.
This is, I just am blown away. This has been great. Now, the last question that we have prepared is, how have you all tracked that your initiatives are achieving the success that you're aiming for. And Dr. Yarrington, I'll turn this over to you. Could you head us off with how you tracked healthcare utilization in your patient population?
Sure. And I will comment that this is a measure of the impact of our postpartum program. I would hypothesize more than our pregnancy program. We're still learning how and whether expansion of this into pregnancy meets the needs for our patients. But postpartum, the integration of a greater community of providers, particularly this integration of pharmacists, because it was hard to track down a doctor, has finally shown us a decrease in our postpartum readmissions for hypertension. This was always the design. When a person comes back after their birth at our hospital, like most hospitals in the United States, that adult person is a patient again. They need to come back, but the baby isn't. And there are numerous barriers that end up separating the mother and child if she needs to be readmitted to the hospital. And so all of this work to monitor at home, get ahead of a need for hospitalization and so on, was in the end to keep the family unit together. And finally now, in this past 6 months, we've seen our postpartum hospitalizations for hypertension, particularly in our Black birthing people, start to come down significantly. It's dropped about 40% compared to a year ago. And we do absolutely attribute that to the ability to get good information by our very intelligent, capable patients, and then respond in real time with what they need to their doorstep.
So I'll just tag on to that sort of when you think about benchmarks and what you want to do to track things. I think really looking for primary care engagement or, primary care medical home, healthcare medical home, looking for connection and being able to measure that, I think is incredibly important because if we just send them out into the abyss, we don't really know what's going to happen to them, and it's not clear that they're going to get the messaging that they need and the care that they need moving forward. And actually now, especially in these spaces that are rural and don't have access to subspecialists, so many family practice doctors and internal medicine doctors are doing everything, including the longer term, long-acting reversible contraceptives and all that sort of work. So getting patients engaged, it's been a big deal. In fact, it's been one of my workarounds for patients that for whatever reason, we've just not gotten them in for their final postpartum visit, or they didn't get contraception like a LARC or some other definitive method addressed at that visit for a number of factors. And so I've often gotten them into primary care, and that's been able to address many of their needs. So it's just a benchmark I think we need to throw out there is to think about long-term health. We do want to save lives in the immediate postpartum, but if you look at the data, really, after the immediate postpartum period, there's a good 30 to 40% of deaths that happen in that 3 months to 1 year. And that's that's the space that I really want to jump after. So thanks. This has been amazing.
I'd just like to maybe go in a different direction. We have our patient metrics, which of course is the paramount metric for our success. But there's another aspect and that I've been monitoring, which is to what extent are providers responding to the new knowledge, the new understanding of hypertensive disorder of pregnancy and the future risk of cardiovascular disease. So I was very gratified when we began with our residents at the hospital on every morning rounds. We have a pre-printed patient checklist. And for those women who had preeclampsia, any type of hypertensive disorder of pregnancy, there's a checkbox. Did they receive their educational encounter? And another checkbox, do they have a firm appointment with their primary care provider within 6 weeks? To get that to happen was no mean effort. It took time, and of course, one always meets resistance to change at first. But I'm gratified that now that is accepted as de facto standard of care. And so that's one advancement that we were proud of.
Okay, well, thank you to our panelists and for sharing how you were able to use these approaches to partner with your communities and improve hypertension control and health outcomes in the populations you serve. We are now going to leave the breakout rooms and go back to the main room to hear from Lieutenant Monica Geiger as she gives a presentation on CPR. We will see you there. Thank you.
Recording stopped.
Hello, we're going to give just a few more moments for folks to transition over to this breakout room. My name is Kiva Nelson. Welcome to all of you. You can go ahead and begin recording. Thank you.
Recording in progress.
Thank you all very much for such an awesome day of activities and events thus far. We are so happy that you all are able to join us for today. So without further ado, I'd like for you all to please welcome me as we like to introduce Lieutenant Monica Geiger. Monica Geiger is a member of the U.S. Public Health Service Commission Corps, and she's a Commission Corps officer serving Region 6 as a regional women's health analyst. And within that, Monica serves the states of Arkansas, Louisiana, Oklahoma, New Mexico, Texas, as well as 68 federally recognized tribes. Monica is here today, and we are so excited to have her as she's going to share with us the importance of CPR and rapid response and perform a demonstration for us. Over to you, Monica. Thank you.
Hi, everyone. Thank you so much, Kiva, for having me. It is such a pleasure to be with you here today. And I want to thank OWH for having me for this really, really important topic. So I want to talk a little bit about CPR. As Kiva mentioned, I'm in Region 6, based out of Dallas. So if you happen to live or work in any one of the states that was mentioned, please feel free to reach out to me. I would love to hear from you. So here in Region 6, we've done quite a few efforts related to CPR education. And CPR education is so important when it comes to saving a life and being ready in case anything goes wrong. Next slide, please. So here in Region 6, we've been taking advantage of the fact that many states actually require CPR training for high school graduation. So we actually started a partnership with the American Heart Association in 2018 to bring CPR into schools. That whole process, ensuring high school students are trained in hands-only CPR before they graduate. So if you live in any one of these states highlighted here, it means that your high school students are required to get a CPR class. And that's awesome because our goal is to have as many people in the community trained in CPR as possible. So we have 38 out of 50 states that require CPR training for high school students. And so that we've been taking advantage of with this partnership with the American Heart Association to go into those schools and demonstrate CPR. And even my cat gets involved. You can see my cat helping me get ready for a class. Next slide, please. And you know what? Anyone can teach hands-only CPR. You don't have to be a nurse, a doctor, or a healthcare provider. If you have a pillow, you can teach CPR. There are existing standardized lesson plans. Again, if you don't have a dummy, you can use a pillow. You could print out a picture of the AED. The important thing is to teach how to do compressions. Familiarize people with the AED. Anybody can use an AED, and I would challenge all of you to learn where the AED is in your office, in your gym, where you in your worship space, wherever you frequent. Know where your AED is, and encourage other people to do the same. So that if something were to happen, you know you have people around you to help. So anyone can teach hands-only CPR. Next slide. So So now let's talk about what CPR has to do with women's health. So over 60 million women in the US are living with heart disease. That's 44% of women. So quickly, by a show of hands, how many people here have ever taken a CPR class? If you would raise your hand quickly. Awesome. So we do have a couple of people who've taken a CPR class. That's amazing. So put your hand, keep your hand up if you've taken one within the past 2 years. Okay, awesome. So this is a perfect microcosm of the data here. So according to the data, about 65% of people in the US say they have taken a CPR class at least once in their life, but only 18% are up to date. It is so important that we refresh every 2 years because there are new guidelines. And high rates of heart disease and hypertension in American adults have made CPR training more important now than ever. And women are less likely to receive bystander CPR because rescuers fear accusations of inappropriate touching or sexual assault. So with that being said, only 39% of women receive bystander CPR compared to 45% of men. And because of that, men are 23% more likely to survive a cardiac arrest. And ladies and gentlemen, that is not acceptable. We need to be performing CPR on everyone. And yes, CPR is the same on pregnant women as well. We all need these skills of CPR, and we all need to be willing to save a life. Next slide, please. So these are some of the next steps that we're planning to take in our office in Region 6, and we would love for you to join us. Reach out anytime. We're going to continue to promote the Assistant Secretary for Health and Surgeon General's initiatives and priorities, including blood pressure control. We hope to build trust in the communities, serve as a resource for information, partner with other regions and partner with you to expand our reach and expand to other venues. We want to teach CPR at gyms, YMCAs, churches, synagogues, other places of worship, community centers, wherever people gather. We need CPR. Next, please. So the dog in the last picture knows CPR, and these people in this picture know CPR. Do you know CPR? I would challenge each and every one of you to familiarize yourself. And with that being said, we're actually going to perform a CPR demonstration here right now live. I have some CPR dummies for you. So we're going to switch over to the demonstration. All right, I am so excited, guys, because CPR is super easy and simple. So CPR, you only have 2 steps. Call 911 and push hard and fast on the center of the chest. That's it. Those are the 2 steps that you need. So right now, I'm going to give you some additional tips to be able to be most effective in your chest compression. Okay, so I'm going to have some folks help me to demonstrate, and we're going to start out with how to do compressions. So all you need to do is extend your hand and interlock your fingers. And what you're going to do is you're going to put the heel of your hand in the center of the chest. And then all you need to do is push hard and fast in the center of the chest. And that's it. You are doing CPR. So a couple of things to remember when you're doing chest compressions. When you're doing chest compressions, you want to make sure that your elbows are locked. Posture is really important so that you're most effective in your compressions and so that you don't hurt yourself. So make sure you're locking your elbows and you are above, right on top of the victim, okay? I don't want to see this, and I definitely don't want to see this. Okay, this is what I call chicken wings. I don't want to see any chicken wings, okay? I don't want to see bent arms. I want to see nice posture so that you can stay safe and so that we can help this victim. Another thing when thinking about CPR that I teach in my classes, the first step when doing CPR that I like to make sure to mention to people is to remember scene safety. When you're about to perform CPR, be aware of your surroundings and any hazards that might be in the area, such as water, down power lines, or other hazards to be aware of. If you're not safe, then you're not going to be able to save a life. So make sure you're safe first, and then you can start chest compressions. So what we recommend is once you make sure you're safe, get out your cell phone and call 911. Put your cell phone on speaker down right in front of you. The operator on the other end will instruct you how to do CPR properly. And then as soon as you've done that, you're going to start chest compressions. Now, the question you may be thinking of is, Monica, what if this person doesn't need chest compression? Well, let me tell you, as soon as you do that first chest compression, they're going to tell you if they don't need it. I promise. So when in doubt, do chest compressions. I promise you won't hurt the person, okay? So do chest compressions is so important, okay? And so we're going to demonstrate some chest compressions. We're going to do 30. And if you can, it's helpful to count out loud so that when advanced medical providers arrive, they know where you are in the process of chest compression. So we're going to get ready. And you can think of a quick song like Staying Alive when you're doing these chest compressions. So ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 24, 25, 26, 27, 28, 29, 30. Woo! That's a workout. And you can practice this at home. Practice with a pillow. Practice with your family, with your friends. You want the people around you to know CPR so that you know there's people around you that you can rely on if you have a cardiac event. So now the next thing and the last thing I want to show you is our AED. So this is a demonstration version of what you might see. Every AED is a little bit different. So I would suggest that you take a look at the AED in your office space, in your community space. So there are only 2 steps to operating an AED. Very simple. Step 1, turn it on, okay? You'd be surprised how many people forget to turn on the AED. So turn it on. And then the second step is to simply follow the prompts. And that's it. Turn it on, follow the prompts. It's as simple as that. So when you are getting ready to do chest compressions, you are going to need to expose the chest so that way you can apply those AED pads correctly, okay? And I'm sorry, ladies, if you have a $100 bra on, it's coming off because this is a life-saving measure that needs to happen. And so in this case, modesty goes out the window. So we are going to expose the chest, and then we're going to apply the pads like I've done here already. The first one goes on the top right side of the chest, and this one goes on the left side of the chest. So pop quiz here. What is in between these 2 pads in terms of the anatomy of the human? Ideas? Inside of the ribs and the sternum? The heart, exactly. So the whole reason for the placement of the pads is so that the electricity can flow from one pad to the other, and the heart will be right in between. So the electricity will flow through the heart. Okay, so that's the important part about placing the pads, is that you want the heart to be in between the 2 pads. And usually these AEDs have these really nice and friendly pictures that will tell you exactly where to place the pads. So if in summary, a couple of things that we've learned here, right, is one, call 911. Okay, that's going to be your most important first step to be able to initiate that emergency response. And number two is to make sure that you're safe at all times. Be aware of any environmental hazards that you might be encountering. And then we're going to lift up the person's shirt or cut the shirt off and remove any undergarments before we then start our chest compressions. And remember, the posture for the chest compressions is very important. And if you have an AED available, that this little device will save a life, and it will help you. It tells you everything you need to know, and it is very easy and user-friendly. So that, in a nutshell, is a quick way to think about CPR. So thank you, everyone, for your time and attention today. I hope you've enjoyed this little demonstration, and I can take any questions if there were any in the chat.
Monica, I have a question. Can you hear me?
Yes, I hear you.
Can you talk a little bit about the transition from to hands-only CPR, knowing that a lot of us are probably taught, I guess maybe the traditional way of mouth to mouth?
Hey, that's a great question. So there's a couple reasons for that. The American Heart Association taught mouth to mouth for a long time, but what they were discovering is that people didn't want to give mouth to mouth. Especially in a situation where the victim was a stranger or a complete stranger. And I can understand the hesitation, and also there's concern about infectious disease and things like that. So the American Heart Association found that teaching the breaths would actually deter people from doing CPR altogether. So instead of promoting the breaths, we're promoting the compressions, because that is what science says is going to preserve that heart while we're waiting for advanced medical support. So what I was taught is time is muscle, meaning when you're having a cardiovascular event, a heart attack, that muscle is actively dying. By doing the compressions, you're doing the work of the heart for it, keeping that heart viable until further medical intervention can be had.
Monica, if folks are looking to get certified for the first time or recertify, where's a best place that they can go to find a class near them?
Oh, that's a great question. The American Heart Association has a great website which has a list of all sorts of classes in your area, so you can search it up. Also, feel free to reach out to my office. I believe our email was on the last slide there. OWH6@HHS.gov. So feel free to reach out anytime if we can be of assistance as well, if you happen to be in the local area. But American Heart Association is an amazing resource to find classes and to find the latest science when it comes to CPR intervention and any other information you might need. Oh, I've got a question in the room.
Oh, please.
Awesome. So the question, in case you didn't hear it, is that are there things that you can do to prevent contagion if you do want to perform the breaths? And the answer is yes. If you are a healthcare provider or you are familiar with breaths and you're comfortable giving those breaths, there are absolutely things you can do. So they sell barrier masks for CPR. I wish I had one with me, but I don't think I do. There's barrier masks that you can actually put over the mouth and nose to be able to create that barrier between your mouth and their mouth. And then also, of course, there are masks, CPR masks that you can actually utilize as well. And advanced medical providers will usually have those things. And also many police departments and firefighters, other first responder personnel, many times have those items on their person if there happens to be someone in the vicinity.
right. Thank you so much, Lieutenant Geiger. Are there any additional questions?
No, but I found my CPR mask barrier, so I'll show you all what that looks
lovely.
like. So I have one from the, let me turn my background off so you can see. 1 second. So mine's from the American Red Cross, so it comes just in this little package, and it has a wipe in it as well. So if you need any clean, and it has a little clip, so you can put it wherever you need it. And then the one I have, I don't know how old this is, but it pops in and out like this, and so you put the mask on the victim this way, and then you blow through the tube right here, and you can put it around their head with a stretchy elastic.
That's perfect. Thank you so much for that. And you know, like I said, if you don't have a barrier mask and you don't feel comfortable doing so, you don't need to do the breaths. Please focus on the compressions if you're not comfortable. Don't let the breaths prevent you from responding. I always tell my classes, do something. When you see something happen, when you see a cardiac event, please do something, even if it's just calling 911. I encourage you, do something. Call 911, start chest compressions. You will save a life. Every second counts in these situations. So thank you.
Thank you so much, Lieutenant Geiger. We appreciate you joining us today and lending us your expertise and teaching us about CPR and rapid response. Everyone, we will take a 10-minute break. Please feel free to join us back at about 2:41, and we will see you after a 10-minute break. Thank you so much.
Produced by the U.S. Department of Health and Human Services.